to all of you to our Wills Student Health Services Center, newly remodeled conference room, so that we can enjoy these kind of presentations. Today we are excited to present to you a very timely topic. Who knew when we were setting this up in July that it would be on the news morning and night, and just so timely in an unfortunate way. So today we have Kelsey Schmuhl. What year are you, Kelsey?
Fourth year.
Fourth year pharmacy student. She spent a month with us in July, and Naloxone and Generation RX and opiate issues are one of her passions. So we're excited that she could come and present about Naloxone in specific, but also give you some background about the opioid epidemic. I'm Dr. Kathryn McKee. I'm one of the physicians here at the Student Health Center. And I'll be talking briefly about medication-assisted treatment and some programming that we can offer here at the Health Center now. And then, last but not least, we have Sarah Nerad from the Collegiate Recovery Community, and she will present some information about how we can prevent or present more support for our students on campus who are going through recovery. So without further ado, I will turn it over to Kelsey.
Okay. If I talk without the mic, can everybody hear me okay? I'm going to try to walk around a little bit and I'll stay behind this podium. Thank you for that introduction. My name is Kelsey Schmuhl. Like she said, I'm a fourth year in the Doctor of Pharmacy program here at Ohio State. I've been an Ohio State Buckeye for 8 years. I love it here. I'm so excited to be here. Thank you all for coming to this program. Like you said, we think this is a very important issue. We're so excited to share our passions with you. I'll give you a little bit more background about why I'm here. So as part of my fourth year of pharmacy, I've been working with Phil very closely throughout my entire year to set up a Naloxone distribution program at our pharmacy here at the Health Center. So this has been, like I said, my passion. I've done a lot of work with Naloxone over the past couple of years. So I hope I can give you all a little bit more information about where we are in Ohio, how we got to where we are with the opioid epidemic, things of that nature. Pretty informal, so if you have any questions or want to, share a story during this, because it's, today, almost everybody is affected by addiction, or they know someone who is. So at any point during this, if you guys want to share, please feel free and stop me. So, like I said, we have some people who may be new to this topic in this room, so I want to kind of give a background about how we got to where we are and where we are in Ohio, so we can start from there. In 2013, the Center for Disease Control and Prevention, the CDC, actually classified opioid overdose as an epidemic. And it called for urgent policy, programs, and community-led responses to this problem. And I think that's really what we're doing here at Ohio State. We're trying to implement policies, programs, and community responses. And it really does take a community for this type of program. So I wanted to start off by, just saying that it's going to take an entire community. It's not just going to be me. It's not just going to be physicians. It's not just going to be Sarah. It's going to take all of us working together to combat this problem, especially here at Ohio State. So here's where we are. From 1999 to 2013, we saw prescription painkiller sales increase by 4-fold. That's the green line. The orange line is deaths. Okay, you can see a direct correlation on this graph. Okay, so this is deaths due to prescription painkillers. So we obviously know there's a direct correlation between sales and deaths due to prescription painkillers. All right, so this next slide shows prescription opioids and heroin. We know that 80% of our people that use heroin start off with prescription pain pills. We just know that's a fact. And there's many reasons why they might switch over to heroin. That could be, efforts in Ohio to reduce opioid prescribing. So this is a good thing, right? We're trying to reduce prescribing, but then that might lead somebody to use heroin. We also increase our prescription drug monitoring program, so that's ORS in Ohio. So, we have tighter controls on our prescribing, but that might lead somebody to use something else. We also closed down our pill mills back in 2010. So, we tried to shut down those pain clinics that are, pumping out a lot of prescription drugs. But, now there's a decrease in the supply of prescription painkillers. So where are they going to go to next? Heroin. We also have tamper-resistant tablets. So, they can't get their high-active tablets anymore, so now they might go to heroin. And then last but not least, I think this might be the greatest reason of all, the affordability of heroin. It's just so much cheaper. I've heard, that Percocet goes for $1 a milligram on the street. Heroin's just such a cheaper alternative that they might just go straight for the affordability factor to heroin. So some opioid overdose stats. This, I just really want you to look at the graph. So back in 2007, deaths due to accidental overdose surpassed motor vehicle accidents. And every year since then, it's been the same trend. Okay, when I came to pharmacy school, or when I came to Ohio State in 2009, I was in Dr. Ken Hale, who was a mentor for me at the College of Pharmacy. He told me this fact, and my mind was blown. I would have never, ever guessed this fact. I mean, this made me want to get into Generation RX. I was like, this is a huge problem, you know? I would have never, ever guessed this. So every year since then, it's been the same. So every year since 2007, accidental overdose deaths have far surpassed motor vehicle accidents, deaths due to motor vehicle accidents. And this data is actually a little bit outdated, probably more than 46 deaths daily in the United States due to overdose. This graph just shows, we saw, you know, in the early 2000s, most of our deaths were due to prescription painkillers, and then it kind of leveled off. Now we're seeing most of them are due to heroin, even fentanyl-laced heroin, carfentanil-laced heroin, things of that nature. So we really have kind of plateaued with prescription painkillers, and we're seeing more of the injectables now. So these are a few stats from Ohio specifically, and this is brand new data I just got a few weeks ago in 2015, which is the latest data. About 8 people die every day. 3,050 deaths in Ohio in 2015, mostly due to multiple drugs. So that could be mixing drugs, etc. If you think about this, that's 1 person every 3 hours in Ohio. That's unacceptable. It's simply unacceptable. So we have a huge problem here. And now, here is our new problem, which I'm sure you all have heard about, fentanyl-laced heroin. So from 2013 to 2014, this is even probably outdated now, we saw about an 80% increase in fentanyl-related overdose. Majority of these, like I said, are fentanyl-laced heroin. Fentanyl is 30 to 50 times more potent than heroin. And now, I'm sure what you're hearing is carfentanil-laced heroin. The DEA just recently, a couple weeks ago, issued a warning about carfentanil, okay? So carfentanil is 100 times more potent than fentanyl. So our law enforcement is at risk, our public is at risk. Carfentanil is lethal even if it's absorbed through the skin, if it's inhaled, if it's ingested. Okay? So what do we do about this? Our police officers are at risk, the public is at risk. So, we're training our police officers, but even they're at risk when they're responding to overdoses now because it can harm them even if it's inhaled or absorbed through their skin. So, yeah.
What is fentanyl?
I'm sorry, fentanyl is an opiate or a painkiller often used in cancer pain. It's a very severe pain, but it's illicitly being made. So it's illicitly being made in Mexico. It's being directly shipped from China. So that's where we're getting it from. It's made in a patch, actually, and they're squeezing the gel out of it. So
not made here in the United States, it's made of
it's made illicitly, so illegally in other countries, but it is made here and used properly for cancer pain and things of that nature. But I would say most of what we're finding in the street is improperly made, illicitly made from Mexico or directly shipped from China, to be honest. Yeah.
If it's shipped right to your house from China.
There you go. Yeah. So it's really scary. And I mean, that's what Dr. McKee alluded to. We're hearing about all these overdoses. You'll hear about them in patches. So you'll see like 50 overdose deaths in one weekend, or not overdose deaths because they're being saved with Narcan, but you'll hear about 50 overdoses in Columbus in one weekend, or Cincinnati had a weekend where they had over 106 days. And it's usually, from heroin being laced with something like this, or carfentanil, because they can it's disguised as heroin. It comes in a powder. They can't tell. So, any other comments about that? Anyone know anything else about it?
Oh no, I was going to ask you what exactly carfentanil is.
What is it?
Yeah.
So carfentanil, that's a really good question, is another synthetic opioid often used to tranquilize large mammals like elephants. It's an elephant tranquilizer. Really good question.
Now that explains 500 times.
Yeah.
Stronger.
Thank you for asking that. Yeah.
I just want to say fentanyl is frequently used as an analgesic agent for general surgery.
It is,
Or so,
exactly.
you know, it's a very potent
Mhm.
pain suppressant, and it's a very potent respiratory
Mhm.
depressant.
Exactly.
What is the benefit of lacing heroin with a much stronger drug?
I think actually users may be more attracted to a more potent high or something like that. So if they hear about a batch, I've even, correct me if I'm wrong, heard if they hear about someone who's died from something, might be attracted to that dealer or to that batch. Correct me if I'm wrong, maybe.
It's true, I have a friend in Lake County that says when they have a lot of overdoses, people are seeking out that particular drug and moving towards it.
It's a better high.
The high is better.
But what would be the benefit of, say, the person who's selling it?
They can get more bang for their buck, I believe. If you have even a small amount of fentanyl or carfentanil and you're kind of diluting it out, it's so potent, I think you can make more, things to sell.
To answer your question, it's also short-term consumerism. They're not concerned about maintaining consumer base. They're concerned about short-term, how much can they gain from it. And so the word of mouth spreads really fast that this is better than what this other guy was selling, so the flock moves that way.
So it's not that they're actually marketing this, it's not as a bad batch per se, it's that they're specifically putting it out that this is something that will
Yeah.
give you better highs, basically.
Exactly.
Okay, got it.
And, yeah.
So I'm actually writing a paper on all this right now.
Oh, great.
And why is there not newer slides and information? Like, everything seems to be so.
Well, we just got the ODH, the Ohio Department of Health information from 2015. I just got that data last week. I can't really
Yeah, I mean,
say.
I don't know why it's not been updated or.
I know, and to be honest, we don't have a lot of, trials or, it's hard to collect data on it, to be honest. I'm sorry. All I can tell you is what I read in news stories and what I've heard by word of mouth.
There's something to be said for the fact that this is history. What the information she has here is the latest information that's available out there, whereas what you or I might see on the streets is what's currently going on. Everyone in the institutions of the police or the medical or everything else, they're collecting the information just as fast, but they need it to be verified. They need it to be accumulated and consolidated and also verified as true before it gets put out. Otherwise, it's pure hearsay, and then we're running a witch hunt. They can't do that.
So I'm sorry if it's not more current.
Yeah.
Yeah. But thank you for the discussion, everybody. Yeah, please feel free to chime in more with your stories. That's great. Okay, so let's talk a little bit about naloxone. So, commonly known by the brand name Narcan, this was actually approved back in 1971 for use by emergency departments for opioid overdose. They didn't start distributing it in community programs to lay people until about the 90s, though, and that's what we're seeing today. Like I said, it's used for opioid overdose, so I have there listed common opioids, for example, Percocet, heroin, Vicodin, Opiana, morphine, things of that nature, Suboxone. Naloxone will not have effect on someone who has not taken opioids, but if you come across somebody and you don't know what they've taken, we encourage people to give it anyway. Like I said, it will not have an effect on somebody who has not taken opioids. I quickly want to go into a little bit about the mechanism of how an opioid causes an overdose, because I think that's important to understand naloxone's mechanism. So an opioid will bind tightly to the mu opioid receptor. So let's see if I have a pointer. So that's the opioid receptor right there. You guys on here, this is the opioid receptor right here, the mu opioid receptor. It binds tightly to that and causes respiratory depression. That means it slows breathing all the way down until eventually, if someone takes enough opioids, they eventually stop breathing altogether. So an opioid overdose usually occurs over about 1 to 3 hours. And long-term users are at higher risk for respiratory depression because they need higher doses of opioids to achieve their high, but they don't become tolerant to respiratory depression. Does that make sense? Okay. So here's naloxone coming in, and as you can see, it binds to the same receptor. It'll kick the opioid off of its receptor and bind tightly, and it will reverse the effects, causing a person to start breathing normal again. However, it also reverses all of the effects that somebody wants to get from an opioid. So for example, all the euphoric effects that somebody wants from an opioid, it takes away those too. So that's why we see somebody go into immediate withdrawal when naloxone is administered, okay? So it's good to know that when say you're counseling in a pharmacy, you want to let that person know if they're going to administer naloxone, they may become extremely combative if they come to, okay? Because that would be immediate withdrawal. Here's naloxone's pharmacology. It's going to work very quickly in 2 to 5 minutes. However, it only lasts about 30 to 90 minutes. We know that most opioids last 4 to 6 hours, okay? So our patients or our people are at an extremely high risk for re-overdose, okay? Once this wears off, the opioid or the painkiller is still in their system, so they're at extremely high risk for re-overdose. That's why they need to get to a hospital immediately, okay? We'll go over the dosing a little bit in a little while, but the adverse effects, to be honest, are pretty mild. This is widely recognized as a very safe drug. The adverse effects that have been reported are usually considered to be part of the overdose process in itself. And everyone always asks me, do naloxone programs work? Like, is what you're doing worth anything? You know, these actually reverse overdoses. And like I said before, we don't have a lot of clinical trials or data on this, but a 2010 report was done on 188 overdose education programs, and it said about 1 in 5 naloxone kits does actually reverse an overdose. And you know what? Every life stage is important to me, so 1 in 5, I think that's great. And actually, I did read a few weeks ago in Ohio, since we started our new law, you know, having pharmacies dispense naloxone, 2,200 lives have been saved. So I think that's amazing. I want to quickly go into a little bit about naloxone counseling. This is what a pharmacist or pharmacy intern has to go over with every patient at the pharmacy, okay? So if you're going to go to a pharmacy and pick up a kit, a pharmacist or intern should go over all of these things with you. So I think it's important to go over them with you today. So here are some risk factors for an overdose. So mixing drugs, absolutely. So if we see painkillers or opiates mixed with benzodiazepines, so things like Valium, Ativan, Xanax, things like that, that puts you at higher risk for respiratory depression because they both decrease your breathing, okay? And then also alcohol does the same thing, both kind of put you at higher risk. And then same thing with cocaine or speed. We say that those are called uppers and painkillers are called downers. So if you mix uppers and downers, the uppers can kind of mask the symptoms of respiratory depression and put you at higher risk. Tolerance changes, absolutely. So if a person doesn't use for a long time, say they're in jail, they're in a detox program, they're in a hospital, and they come out and try to use the same amount that they did before, they're at a much higher risk for overdose because their tolerance just isn't the same. The quality of the drug. So if a person uses a new dealer, so for example, if they go to a new dealer who's now lacing their drugs with fentanyl or carfentanil, and they don't know it, they could be at high risk for an overdose. Using alone, we always encourage people in basic harm reduction. If they're going to use drugs and we're not going to change that, at least don't use alone. Because if you overdose, we at least want someone there to be able to call 911 or give you Narcan if something happens. And then generally just the health of the individual. So if you have bad liver, bad kidneys, a breathing disorder, they put you at generally just higher risk for overdose. Okay, so recognizing an overdose. So generally their breathing's going to be very slow, shallow, erratic, or just stopped altogether. They might be making like a gurgling, snoring sound. They might be pale or clammy. Their fingernails will be blue. Their lips might be blue. They won't be responsive to general just stimulus. We recommend doing a sternum rub. And instead of me practicing on myself, I'm going to show you. I think it's more effective if I have internet. Do I have internet?
Oh,
Maybe? Yeah.
okay. I don't know. I used to, yeah, OSU wireless.
You don't have to do that. So just like that, just forcefully and quickly rub your knuckles right over the breastbone like that, okay? If someone doesn't respond to that, that's how you know that it's probably time to do the rest of these steps, okay? So If they don't respond to a sternum rub, we want you to call 911 immediately. So remember earlier I said the naloxone, once you give that, is only going to last 30 to 90 minutes, okay? So they're at extremely high risk for re-overdose if opiates is what they overdosed on. So we need to get them to a hospital, okay? So call 911. Next, we want you to start rescue breathing or CPR if you're trained. Sometimes it's just an oxygen issue, to be honest. We said, you know, like I said, respiratory depression, sometimes they just need some oxygen to their brain. So start rescue breathing. Those are the steps there. Do that for about a minute. If nothing happens, we want you to give the naloxone. It's much easier if it's a 2-person rescue. Have someone start the breathing, someone put together the naloxone kit during that minute. Then assemble and give the naloxone. Next, you'll do the rescue breathing for about 2 minutes. Like I said, if they don't come to in about 2 to 4 minutes, we want you to give that second dose of naloxone. Every naloxone kit you get from a pharmacy should have 2 doses in it, okay? All right, here's the fun part. I did bring a demo kit, so you can see this. All right, and you guys can practice this after the talk today. All right, so first step, your naloxone kit will come with 3 parts, okay? This is just water. This is what the naloxone comes in. It comes in a vial like this. In a real kit, this cap would be purple, just like the one in the picture, okay? First step is to remove all caps, so both yellows, and pretend this is purple, okay? This little piece is called a nasal atomizer. This is what turns your drug into a mist. This screws right on top of here, like this. And then your vial of drug screws right into this right here. Only turn until you feel resistance, and that turns into this. Okay, so there's 2 milliliters in this syringe, or 2 milligrams. Each milliliter is 1 milligram. We want to try to get about 1 milliliter in each nostril, okay? It's not a perfect science, so if you're in the heat of the moment, just try to do your best, okay? Try to aim towards the ear. There's actually more area on the side of your nose to absorb, okay? And I'll show you. This sprays like a mist. Okay, just like that. Like I said, you guys can practice this after the talk today if you want to. Lost my clicker. There we go. I did add the other dosage forms of naloxone in here just for completeness. This is the newest form. It's the brand name Narcan nasal spray. It requires no assembly and it all goes into one nostril. So all you have to do is just peel back the packaging and insert it into one nostril. I brought this form today because it's the most common in our community programs. It's the most cost effective. This one's a little bit more expensive. This is the traditional vial and needle, kind of like a flu shot would be given. We don't really see this because people don't really like to give injections, things like that, so we don't really see this much in our community programs. This one is a really nice dosage form. It's called the Evzio Auto Injector. It's an intramuscular injection, and it's a little device that talks you through the entire process. It's a very nice device. However, the cost really limits its use. It's last time I checked over $3,000. Yeah. Okay, so some key points from our little training session we did just then. Remember, naloxone is an opioid antagonist or blocker. It's used to save someone's life when they've overdosed on opioids. But remember, if you don't know what someone's overdosed on, we want you to give naloxone anyway. It works within 2 to 5 minutes to allow a person to breathe again. But remember, it only lasts for 30 to 90 minutes, so make sure someone gets to a hospital. It's safe. It's generally regarded as safe. And I added the last bullet point in because when we were testifying on the naloxone bill a couple years ago, a legislator asked me if you were supposed to give it to yourself or someone was supposed to give it to you. So I always add this in and just remind everybody that naloxone is meant to be given on somebody else who is overdosed and not meant to be used on yourself, just in case there's any questions. And I quickly want to end out with just the legal status of naloxone in Ohio. It's legal for naloxone to be dispensed in all 50 states with a valid prescription written by a physician. However, in 24 states, pharmacists are allowed to dispense it under protocol, which is what we have here. These were the 2 laws that allowed naloxone access to be expanded. So the first one was House Bill 170, and this allowed physicians to write prescriptions for caregivers or family members, things of that nature. And then House Bill 4 was what the most recent one that passed in 2015, and this allowed pharmacists and pharmacy interns to dispense naloxone without a prescription under a physician's protocol. And that's all I have about naloxone today.
I have a question.
Yeah.
So is there any information or data about multiple uses? So if a person needs it over and over and over and over, is there a tolerance that develops or anything like that? Because it seems like that could potentially happen.
Yeah, I have heard of that happen. I don't know about data, but I have not heard of people developing tolerance to naloxone. And I have heard that needles will continually give it until EMS arrives if it's available. So, you could give it probably pretty much every 2 minutes until help arrives if somebody is overdosed, and I have not heard of a tolerance developing.
So my point is, with a lot of the addicts, they're
Mhm.
statistically not going to
Yeah.
become addicts.
Mm-hmm.
And so I just wonder, can they get it 10 times, 12 times?
I've heard of someone getting Narcan like 8 times. And I don't know if I'm.
Yeah, how would you even know,
Oh.
sorry, how would you even know to have it ready, like, have it at your house as soon as we do this, somewhere in your family?
Yeah, so I would say, if you have a loved one that, has a problem with opioids or, things like that, I would have it kind of like a fire extinguisher in your house, and just have it ready. That's how, an analogy I've heard. And, or like an EpiPen, just things of that nature, just have it. A lot of parents have come up to our pharmacy, who have children, with an addiction, and they just have it in their home, or they carry it with them in their purse, or things like that. So, but if you don't know that there's an addiction, then it would be hard. Does that answer your question? Yeah.
Can you tell us about what it looks like for someone to say come to the pharmacy and request an ACO? How that sort of conversation would go and what information they need to do in order to receive it?
Sure. So sometimes it occurs like over a phone call, or sometimes someone will call the pharmacy and ask, do you carry it? And we'll say, yes, you can come to the pharmacy and we'll give you the education. It takes about 15 minutes to do the full education. We usually take them in a private counseling area. Luckily, our pharmacy is equipped with 2 beautiful counseling rooms with privacy, so we can go in there. I would go through all of the steps on there with them. I would have them practice on a trainer such as that. I would have them show me that they could do it. They would need, it depends on who it's for. Like, if someone came up to me and said, they had a prescription, I could potentially bill their insurance if they had a prescription for it. Right now at the pharmacy, we're doing cash only.
And
So
how much is it typically?
it's about $100.
$100 for one, okay. Wow.
Yes, for this kit. The billing is kind of hard right now because this is the first medicine of its kind that a caregiver could come request, but they aren't the end user.
Well,
Does that make sense?
yeah, no, I understand.
Yeah.
And as I'm hearing you and as I'm listening to you about this, and she posed the question, how would you know whether you should have it or not? Incident actually comes up where not only am I prescribed opioids for pain treatment, but there's another individual in the family who is almost wheelchair bound, who is also prescribed opioids. Now, in our family is quite extensive and likes to get together for holiday situations. There's a number of teenagers in the family that have been known to raid your pharmacy, not pharmacy, raid your medicine cabinet. So anytime that we get together at this individual's house or my house, we have to go and lock up all of the medications. Unfortunately, because the teenagers are reckless.
Yeah.
The teenagers are just interested in that moment of the high, like you were describing earlier. So here's a case where with that individual who is near wheelchair bound, he generally has a mobility issue. Or for what's prescribed for myself, which is in a small dose, but it's for when my back pain goes to extreme levels that the gabapentin doesn't work, and I would go to the opioid for the neutralizing of the pain. That's a case where having this handy would be a nice insurance.
A lot of insurances are covering this for a copay or no cost.
Mine's covered through BWC.
There you go. I would recommend you have your physician write a prescription for it, and you can take it to a pharmacy, and I would be willing to bet it would be covered.
Yeah, I think the recommendation has been for people who are taking chronic opioids, we don't expect that you'll overdose or whatever, but by mistake mixing things, ask your doctor for a prescription of the naloxone. I mean, those are the ones that are,
100%.
I think pretty much no question should be covered by your insurance.
Yeah.
It's for you.
Would BWC cover it? That was my question.
That,
They're on that.
BWC is a whole nother thing.
Yeah, it is a whole nother thing, and
So
it's-
I don't know, sometimes they're
hard
on
road
front,
wrestle.
sometimes they're not.
I've never billed one
Okay.
BWC.
Mhm.
I have had,
Just curious.
I've had good luck with, some other insurances though, and I think it's becoming more widely recognized as, you know, this is something that
And in
more
that
people are
case,
dealing with.
you would tell your family,
Yeah,
here's where my
absolutely.
kid is. I keep it, or as a student, I keep it in my book bag.
Mhm.
I keep it in the medicine cabinet, I keep it under my bed or my sock drawer or whatever, you know.
Yes.
So, yeah, I think that's very reasonable for anyone who takes chronic opioid medication to have a kid.
We tell even family members, you know, if they're being discharged from the hospital on chronic opioids for cancer pain, things of that nature, or if they have a chronic condition where that it slows breathing. I mean, even, you know, like a COPD patient who may be prescribed opioids for something else. I think there's a lot of perfectly legitimate reasons to take opioids that we just aren't thinking about having this at home that could result in an overdose. So I think those are perfectly valid reasons to ask your doctor for a prescription. All right, I'll let Dr. McKee take over. Thank you guys so much for all your questions, and I'd be happy to answer more after.
Yeah, there'll be questions, time to have questions. So, I'm gonna say just a few words about medication-assisted treatment. Here at the Student Health Center, our job is not to be a detox facility. We refer students to the appropriate mental health professionals and drug and alcohol assessment places like Talbot Hall, CCS, where we have counselors to do that and to get the process started. Detox, we don't do detox here, that's not our function. So our mission is to really continue the extraordinary student experience by helping students maintain their health and hopefully their recovery path as they are here, you know, exploring their life as an OSU student. So it came about that students were asking, is there a provider on campus who can continue my Suboxone prescription, for instance? And at the time, there was not. So for the last couple of years, we have kind of hammered out a protocol in conjunction with CCS and the Collegiate Recovery Community, where we now have a couple of providers who can prescribe Suboxone, which is a semi-synthetic opioid. So I'm going to tell you just a couple things about medication-assisted treatment and why that has a place, perhaps, for some people who are struggling with opiate addictions. Let's see if I can do this right. So just like patients with other medical conditions, many who are opioid addicted have been found to respond best to a treatment that combines both pharmacological and behavioral interventions. Some people, they don't need both, meaning they may not need the medication. But for a lot of people with opiate addiction, the combination of both is helpful. Now that we have come to understand so much more about addiction as a chronic relapsing medical condition, we are also understanding the place that medication can have in that recovery. So the ultimate goal, of course, is abstinence. We would like to see these folks live a life free of drugs, period. But with opiates, there is such a high relapse rate that until we can get them to a place that they can understand how they got in this mess, and maybe go through all kinds of psychosocial situations, maybe clean up some medical situations, some psychiatric situations, and get the proper care, we got to help them feel good enough to do that. Otherwise, they're going to relapse fairly quickly. So we need to control the physical cravings and the withdrawal. We need to treat the other medical and psychiatric conditions that can be what we call comorbid conditions. Otherwise, if I'm hearing those voices, I got to quiet that down. I'm going to use something because I can't take it, you know. So we got to take care of the medical and the psychiatric conditions. And that's been a problem in the past. When we have not looked at substance abuse as a medical condition, people would want to treat one or the other, and you really need to treat them both at the same time. And then a lot of these people may have started using opiates at a very young age. They don't have life skills, basic life skills. How do you talk to your landlord about the rent without being high? I mean, that kind of thing. So the sober support, the community meetings, terribly important for these people to kind of get their life back together. Medication-assisted treatment can, in some cases, decrease the risk of relapse for a lot of these folks who are struggling with opiates. So another receptor picture. Receptors are our favorite thing. So this orange or this purple receptor is empty and it's screaming. It's ready for something to come and fill it. Without something in there, you may experience pain or anxiety, and the completion of this receptor makes you feel better. So whatever I got to do to fill that receptor, I'm going to do. The nice green one is the opioid. So that could be heroin. It could be methadone. It could be morphine. The buprenorphine, the medicine we're going to talk about in a minute, is the yellow little dots. Or it could be naloxone or Narcan, some kind of antagonist that kind of fits right down in there. Here's a nice perfect fit. When you get the perfect opioid in there, your cravings go away, you might feel euphoric. We're going to talk about methadone, like not at all. Methadone, though, is kind of the gold standard. That was the first kind of, well, pharmacists, correct me if I'm wrong, I'm not a pharmacist, but I mean, for us as doctors, that was the first thing that comes to mind when we think about medication-assisted treatment. You have to be a federally licensed and certified opiate treatment facility in order to prescribe methadone. We are not interested in doing that here at the health center ever. And we don't have that kind of licensing. So the problem was, though, methadone is a daily medicine. People have to go in every day to their treatment facility and get their medication. It is tightly controlled, and there's very mixed feelings about the success of methadone. So they came up with this new medicine. This is supposed to be the answer for family docs who have opiate addicts in their practice, who want to be able to treat people in a safe way as an outpatient. Buprenorphine was used for many years in GYN situations, hospital situations. It is a semi-synthetic opioid, so it is a partial receptor agonist, which means that it'll fit in that receptor, but it doesn't quite do everything that the other opiates do. So it'll satisfy some of the cravings, it'll make you feel a little bit better, not as much withdrawal, but it doesn't give you as much of a euphoric feeling. So it controls those physical cravings. They come in nice little sublingual, meaning they melt under your tongue, little film strips that are in a very difficult to open envelope. And that's for child safety and safety of others. It requires the standard of care is monthly physician visits where drug screening would occur, discussions about what other kind of counseling and support you're getting. You're in drug screens, did I say that? You're in drug screens. But this medication can be, because it is a synthetic opioid, it can be abused and it can be diverted, meaning it can be shared or sold to other people who want to buy it from you. So there are some concerns. Buprenorphine, I've worked in a place and prescribed a lot of buprenorphine. It can be a miracle drug for a lot of people who are motivated to use it correctly and who are surrounded with the other kind of psychosocial supports. It can also be not used correctly and overprescribed and just another problem. When people are ready to come off of Suboxone or you're ready to taper them off of Suboxone, for some people it can be a very painful taper. I mean, they may feel those cravings because they're not taken care of anymore. We're decreasing the dose. So I found that you have to decrease the dose very slowly, and they have to use their tools of recovery kind of to the max as they're coming off of the medicine. So the most successful people are the very motivated. There are a lot of people who aren't so motivated. So here's the imperfect fit of the buprenorphine in our receptor. Not as much of a high. Most people will tell me that they feel normal for the first time in many years. Here's a picture of the film strip and the difficult to open packaging. And there again, a few years ago, there was a big push too because of the whole child safety issue. Children were getting these and you can die. You know, it's the same kind of problem with respiratory depression. These are not made for children. So we actually encourage people to lock them in a safe. And those are available in our pharmacies, well, little lockbox that you can get. So the SMART program is something that we came up with after hammering out this protocol. Suboxone, maintenance, assisted, and recovery treatment. To start with, we are trying to get students who have had 12 months of stable recovery. And that might be hard. So far, we don't have anyone in this program. We were a little late getting our advertising out in the end of July, but we're hoping that with Sarah Nerad's spam email list and Kelsey's connections and getting the word out that we can hopefully attract some students who will come here to Ohio State University because we have the supports in place for them. It would still require monthly physician visits with urine drug screens and the possibility of random urine drug screening as well. And we have established the protocol to also include 3 weekly meetings. So this seems like a pretty intense system. Like, what student would want to do this? Students who are in recovery who want to come to the university and be successful. So the 3 meetings could be 1 meeting at counseling and consultation, 1 meeting at the community recovery community, Collegiate Recovery Community, and 1 meeting of their choice in the community, King Avenue United Methodist Church, NA meetings, you know, there's community meetings all over, and actually we encourage that because eventually they will leave here, and we assume that they will need to go to meetings probably for the rest of their life. Anyone interested can contact the case manager at counseling and consultation. So here's another medicine that's kind of hot in the recovery community that we're trying to figure out where this fits in. This is called naltrexone, and naltrexone is an antagonist. So that means it has no opiate effect at all. So it fits in the receptor, and it's a very strong receptor bond. So other opiates, if you try to take opiates on top of it, it stays in there tight. So when you take this medicine, there's no sense in taking heroin or using Percocet because it's not going to do you any good. So it's a little different in the way that it works. In order to start this medicine, because it's such a strong bond to the receptor, you have to be clean of opiates for 14 days. So when's that going to happen? If you're in prison or jail, or maybe in a detox program that you have been in safely for 14 days not using. So otherwise, you give this to somebody who's got some opiates in their system and they'll get very, very sick. So once you're on this, then you're good. But to start people, sometimes it's a little more difficult. You can use it either in injectable form, so it would mean monthly doctor visits or office visits, or they're in the daily tablets, the Revier naltrexone.
So what happens to an individual who has this, but then goes and tries to take an opioid?
Good question. You'd have probably a lot of opioid in your system, and there would be a possibility of overdose.
So this could cause an overdose?
It could be a factor.
Could be a factor.
Could be a
So
factor.
there wouldn't be necessarily a reaction between this and the opioid?
Call on my pharmacy people. Not so much a reaction. I mean, it's already in the receptor.
Right, so I'm thinking about
No.
the person who has taken this, but then, quote, falls off the wagon,
Right.
goes and takes an opioid,
Right.
not paying attention to the fact you gotta stay off the opioids. I was wondering what the negative reactions would be, what would happen.
I think you would have to take very, very large amounts
Yeah,
to overcome
override.
this mechanism.
Oh, okay, so the person who is seeking the high from the opioid with this in their system, they would end up taking so much opioid that
Yes. I think you would have to take very, very large amounts
Okay.
to overcome it. But I think like someone who just took like a couple Percocets or something, I don't think could overcome that. You wouldn't feel the high. Because it's blocking the receptor where it binds.
So the idea of this is to prevent the person
Yes.
from even wanting to go
Yes.
again.
Right.
Exactly.
So, okay, so in the drug and alcohol place that I used to work, I worked with lifelong heroin users.
Uh-huh.
Probably not a medicine for them. But if you had a impaired professional, if you have a lawyer who's gonna lose his license, you got somebody who, I mean, a highly motivated, you got a college student who wants to get his PhD in physics. Highly motivated people are probably the very best candidates for this.
Okay.
This also, if I just say, like reduces cravings too. From my experience with it, do you have that on there? Oh, I was gonna say, I had some experience with this in August. I was doing inpatient psychiatry for a month, and we used this almost very religiously because we had the luxury of detoxing in the facility, inpatient facility. And from what we found, it kind of takes away that voice in your head that says, go get the high, go get that drug, and allows you to go about your normal functions, like have a job, have a family life, things like that. So I think this is kind of the future of MAT, to be honest.
So those receptors are satisfied.
Yes.
Yeah. Monthly physician visits, we would probably do urine drug screens, the whole same kind of thing. We want to get that whole recovery plan in place. This is not so likely to be abused or diverted. Who's going to want this? And you can stop it when you're done. Not this painful taper kind of process. The injection is expensive. How much is it now, Kelsey?
About $1,500. They do have a copay card on the website to help with the cost. I think it's like a $500 help. That helps.
It's like crazy expensive right now. Yeah. The tablets, not so much. But the beauty of the injectable is that it's in your system and you don't have to remember or forget to take the pills if you choose to. You know you're going to go out this weekend or whatever. So we don't have a component here, a speaker from counseling and consultation, but I think that it's terribly important to remember that just as or more important part of their treatment is the psychosocial component. Individual and group therapy, sometimes you have to establish what level of care is appropriate. Is it inpatient? Is it intensive outpatient? Is it outpatient? Are they just good coming to the doctor's office once a month and going to some meetings? Cognitive behavioral therapy, oops, sorry, got a little excited. Sarah's coming to talk. Family or couples therapy, there again, somebody who's been in addiction for several years and they go back into their partnership or their family, now a clean and sober individual can change the whole family dynamics. So sometimes the family and the partner needs to be included. That comorbid mental health treatment, whether it's anxiety or depression, post-traumatic stress disorder, victims of assault, whatever, all that needs to be addressed. Those life skills, they need to know how to pay their bills. They need to know how to use a credit card responsibly, or one of my best Suboxone stories was a guy who said, I saw my landlord in the hallway, and I wasn't afraid to talk to him for the first time in my life. I could pay my rent. I wasn't high. I wasn't running out the back door. I mean, it's just like crazy simple stuff like that. We take so for granted. And 12-step or whatever your favorite community is. All right, I think that's all I have to say. Yeah.
Aren't either of these drugs contraindicated to have the chemistry?
I would say semi-contraindicated. I know in particular, Suboxone, you're not supposed to use it with liver disease. However, you weigh the risks. And there again, the population that I was working with in Springfield, Ohio, were lifelong heroin addicts, and they're going to die. And so I treated people with hepatitis. I tried to get them in to see a hepatitis specialist and all that kind of stuff as well. But if you don't help them with their heroin addiction, they're gonna die. So you try to get them help for the comorbid medical condition, and you watch their liver enzymes carefully and watch them for jaundice and all the other signs of liver toxicity. And if it becomes a problem, we have to stop it.
Because a lot of the community hepatitis treatment programs, that's 3 days.
Yeah.
And it's-
So it's that vicious cycle. How are you gonna do that if you can't use the medicine because, yeah.
I was
So
just curious if maybe this is a.
I think you can use it. I think you make the patient very aware of the fact that this could make your liver sicker. And so we're gonna watch you very carefully, and you need to tell me if you have any of these things going on. You know, when you run through the list of things that might be signs of liver toxicity.
Oh, so that Suboxone could hurt the liver.
It's metabolized by the liver.
Uh-huh.
So if the liver's already damaged, then it's
They're
not
at
gonna.
risk.
Yeah, they're at risk.
Okay.
How would you know if somebody is using heroin? How, if they're an addict, or what are the symptoms, or how do they act?
Well, actually, I'll turn that over to
Yeah, so we've got, I think, like 10 minutes left. So we're gonna run through and talk about recovery, and I'll kind of speak to that. So my name is Sarah Nerad. I'm the program manager for Student Life's Collegiate Recovery Community. We're located over in Lincoln Towers, so just like a brisk 4-minute walk that way. 6 if it's less brisk. But I think more importantly than that, I'm a young person in long-term recovery, which for me means I've not used drugs or alcohol since August 16th of 2007. So I can speak to this from both a personal and professional standpoint. I think when we talk about addiction, it's really hard to just look at someone because sometimes they look just like me, right? I could still go to class, I could still hold down a job, kind of kept up outward appearances. But with heroin, so opioids make you really itchy, so scratching, it's a depressant, so they're not gonna be like at a party like talking a whole lot, they're gonna be down. You can look for track marks, things like that. There's a lot of great information out there about like more specifically, like people talk about if spoons are missing. I can't remember if the pupils get small or big, but they get small. Small, but I think other drugs do that too, so, there's a lot of ways to kind of figure that out.